This podcast is intended as healthcare practitioner education only and is not a substitute for medical advice, diagnosis, or treatment.
I didn't want to brag to people, but I'm just like, no, I'm not sick. Like, I get up and I'd be totally fine. And I really wasn't showing. So it wasn't until probably about 20 weeks, like I just looked like I was a bit bloated. And it was just, everything was going perfect. Until towards the end. And then everything sort of went downhill.
So we certainly know that between 5 and 10 babies per 100 are born preterm in Australia due to preeclampsia or the complications associated with preeclampsia. So I would say at a very rough and ready estimate that the numbers of preeclampsia cases that I see are probably close to in line with those sort of stats, if not maybe a smidgen higher, just because of the higher risk nature of the patient group I'm predominantly working with.
With gestational hypertension, it's new onset hypertension that occurs at 20 weeks gestation or after without any other causes. So it's not a chronic that's just got worse, or it's not on the background of, say, kidney disease, for instance. And preeclampsia is hypertension, and usually with proteinuria, but not necessarily.
So without kind of launching as the kind of poster girl of preconception, we definitely know that when people have been making all their dietary and lifestyle, changes, because it's to prevent hypertension, first trimester health is a big part of that kind of picture. So if they've been doing a lot of the preconception, we really can mitigate against those risks.
This is Bioconcepts Between Clinical Minds, the podcast that's open-minded enough to take in all sides of a clinical story. You'll hear from researchers, doctors, naturopaths, nutritionists and patients. We look at common clinical presentations through a different lens. It's open, frank and sometimes controversial. Nothing is off limits. Will it change the way you treat? We'll leave that up to you. In Season 2 of Bioconcepts Between Clinical Minds, we look at cardiometabolic health. We talk to experts in the field who will take you into their clinics and share their experience. I'm Tony Chambers, and this is Bioconcepts Between Clinical Minds. In this episode of Between Clinical Minds, we change gears slightly to discuss gestational hypertension and preeclampsia with naturopaths Amanda Haberecht, Belle Rowntree and Jane Hutchens, and we also hear a mother's experience of preeclampsia. Hypertensive disorders of pregnancy affect 10 to 22% of pregnancies in Australia. Jane Hutchens is a registered nurse and naturopath specialising in reproductive health. She's completing her PhD in cardiac disease in pregnancy and the first year postpartum.
Chronic hypertension is hypertension in pregnancy. It's diagnosed up until 20 weeks gestation, and the woman may have known about it before conception or may not have, and it may have just been revealed during pregnancy because of the additional cardiac load of pregnancy. And the cutoff for that is 140 over 90, so greater than either of those. With gestational hypertension, it's new onset hypertension that occurs at 20 weeks gestation or after without any other causes. So it's not a chronic that's just got worse, or it's not on the background of, say, kidney disease, for instance. And preeclampsia is hypertension, and usually with proteinuria, but not necessarily. So the diagnosis is gestational hypertension, so after 20 weeks. You might have proteinuria, or you might have symptoms of kidney damage or liver dysfunction or some of the neurological symptoms. You might have HELP, so hemolysis and thrombocytopenia, and or fetal restriction. So they're working more these days on some of those other symptoms rather than simply saying, do you have protein or not? So it's a bit more complex because it's such a complex condition and multi-organ and multi-system condition. And preeclampsia is usually diagnosed in pregnancy, and sort of the further along in pregnancy you get, the greater your chance. but it can also be diagnosed postpartum. So it's rare, thankfully, but you do hear of those women who are completely fine and then 12 hours postpartum have a stroke because they actually have preeclampsia.
Oh dear.
Yeah, so looking, and you can have a thing of preeclampsia that's superimposed on top of chronic hypertension as well. So that's kind of just being greedy. You're having a bit of everything. It's just not enough. So combined, they're called hypertensive disorders of pregnancy. And when you're looking at the literature, you have to kind of remember, it's like, oh, okay, is that all of them or are they just talking about gestational? But strictly, that's kind of all of them bunched together. And because it's on a continuum. So if you have gestational diabetes, you've opened the door to preeclampsia, which is why they kind of lump them all together. And it can be hard to work out when you've moved from one to the other because it isn't hard and fast, and every individual has kind of almost their own cutoff. So if you're normally hypotensive, you may not have to get to 140 on 90 to be really symptomatic.
And the ramifications are huge, aren't they?
Absolutely. Absolutely. So the ramifications are kind of based on what the risk factors are, but also just on what happens. So the risk factors for chronic hypertension are just, your garden variety risk factors, family history, obesity, other medical conditions, some medications. And the big one for me or my client base is polycystic ovary syndrome.
Mm-hmm.
And all those things are risk factors for gestational and preeclampsia. But where I say in Australia about 6 to 7% of women have gestational hypertension, it's actually higher in first-time mums. It's about 10% in a recent study. So looking at other risk factors, so for preeclampsia, it's having had it before, your mum had it, your sister had it, granny had it, having had pre-gestational diabetes or just garden variety diabetes. If you're older than 40 or younger than 18, so you're at those extreme ends of age, if you have twins or triplets or more, if you're unlucky or lucky, I'm not quite sure. And interestingly, if you're more than 10 years since your last pregnancy, and part of that might just be because you're 10 years older, and women with low vitamin D are at risk of preeclampsia. There's quite a big kind of correlation there.
And can we just explore a little bit more that link between polycystic ovarian syndrome and these hypertensive disorders?
Yeah, well, it's complex. So there's the hormonal aspect, so increased androgenic effects, increasing blood pressure, but also insulin resistance. Insulin resistance increases arterial stiffness, increases hypertension, increasing cortisol. It's inflammatory, and preeclampsia, and particularly at that interface between placenta and woman, uterine wall, there is an inflammatory oxidative process going on. So all of those things that we know are disturbed within polycystic ovary syndrome kind of get amplified once you're pregnant. So that in itself is one thing that drives me mad when people say, go on the pill because you've got PCOS. We want to manage your symptoms and reduce your risk of endometrial cancer. Yeah, cool, good. Then come off the pill and go on IVF. So it's like, okay, you've gone on the pill, haven't addressed the underlying issue. You come off the pill, which gave you a little bit worse insulin resistance, and now we're giving you IVF. So, get ready for preeclampsia. It just seems to be such a inefficient way to manage. But that's also where we come in.
Amanda Haberecht is a women's health naturopath from Sydney who's been in practice for 25 years. She says there are some interesting risk factors to be aware of.
Definitely if they've got autoimmune disease or kidney disease, even women who are kind of presenting with, antiphospholipid syndrome, if they're presenting with lupus, that we know that they're going to be at increased risk of definitely developing hypertension. Of course, age is a risk that we know that the older we are, the more kind of exposed to oxidative stress and methylation issues and potentially inflammatory issues. IVF is also a risk, but it's interesting because the research isn't just about IVF per se as being an increased risk, but more likely you can see that risk with hypertension where there is some donor material, whether it's donor eggs or donor sperm, for that woman. So it's that additional exposure to kind of unfamiliar DNA that will put her at risk of developing hypertension. And first pregnancies, without a doubt, are a more increased risk. Equally, first pregnancies, all those women who have had already a past pregnancy where they, struggled with gestational hypertension or were bordering on preeclampsia, we know that those women, we have to hold them a bit closer and be a bit more preventative with those women as well.
And can you explain that mechanism between autoimmunity and increased risk?
There's mechanisms of inflammation, and we're still trying to really kind of understand it. And the research is still really kind of trying to understand it too. And that there's the risk of hypertension, is related to kind of placental insufficiency. So that can kind of set out right from that first trimester with if there was kind of questions around implantation risk. And that's why, we also see that women who are more likely to develop gestational hypertension, they're more likely to have history of implantation failure, miscarriage history, intrauterine growth restriction. So we know that you have to kind of look at that whole spectrum of first to third trimester health. And, fascinatingly, it's just so fascinating that we know that the paternal genes play a role as well. And again, it's really, requires a lot more research, but we know that there's some kind of autoimmune mechanisms that are at play, because pregnancy hypertension is much more common not only in first pregnancy, but first pregnancy with that paternal material. So if that woman goes on to have another pregnancy with another man or another sperm donor, her risk for developing hypertension elevates again. And with every subsequent pregnancy with the same man or sperm, the risk actually minimises. So we know that her immune system is having a response to paternal DNA. And paternal DNA is, again, and it's a lot of kind of emerging evidence, but really fascinating evidence that paternal genes have been really found to regulate placental development and are really responsible for the fetal side of the placenta. So, and that those early development of blood vessels of the placenta into the uterine wall. So if that woman's immune system, so if she has already kind of pre-existing, inflammatory, autoimmune miscarriage mechanisms going on, that we know her immune system can have a bit of a response potentially to that paternal DNA.
That's really interesting.
It's fascinating. We know that if a woman has had a past history of disordered eating, that is also going to increase her risk. We know that the closer her pregnancies are will increase the risk, and there's kind of questions around, is that because of increased oxidative stress or less time for, maternal nutritional recovery between her pregnancies? So we know there's a lot of nutrients that are associated with risk, vitamin D deficiency, great studies around, if women are low in antioxidants like vitamin C, vitamin E, it's also going to increase her risk. Elevated homocysteine will increase her risk. So that's why when you've been able to kind of work with that couple or that woman right from preconception, we've captured all that information. We've tested her for that. I routinely test, pretty much all my patients' homocysteine levels, all their vitamin D levels. We're often checking their blood sugar or their HbA1c if we know that they're insulin resistant. So the earlier you can get on top of all those risk factors, that you're going to have better outcomes for her.
Belle Rowntree is a naturopath from the Mornington Peninsula and, like the others, is a strong advocate of preconception care for mum and dad.
Without getting on my soapbox, because paternal preconception care is one of my absolute passion areas, but what isn't often spoken about is the paternal factors that can influence the health of the mother through pregnancy and can certainly influence preeclampsia risk as well. So we know that paternal obesity, so paternal BMI, is just as important as maternal BMI for preeclampsia risk. So it certainly can be a very powerful conversation to have when they come in to see me, to kind of expand the thinking of the importance of preconception care for men, because certainly they have a significant influence on the conception process. They're certainly contributing information to the future health of their baby, but what's often not spoken about is also their potential to have a very positive influence on the health of the pregnancy as well. So that's always one of the things I'll happily jump up and down about.
Honestly, it was the perfect pregnancy. So from when I found out, it was very early days. And yeah, I had no cravings. I wasn't sick at all.
Alex Hill's now mum of boy-girl twins and a naturopath.
And it was just, everything was going perfect until towards the end. Okay. And then everything sort of went downhill.
So what happened at that time, that 24-week mark?
So around then I started to notice that obviously I started to show, and my, started to get a bit puffy, and I've always sort of been a bit paranoid of having a bit of a moon face. And I noticed that, it's like my face started to sort of swell, but my biggest thing was my feet. My feet and my ankles started to swell, and I started to, I guess, obviously get a bit nervous. But again, first pregnancy with twins, it's just like, okay, well, fat feet, it's a thing, right? Like, it's just part and parcel. Yeah.
And so what happened when you went to the doctor?
So I was having regular midwife checks. The great thing was, because I'm here in Brisbane, I was going to Mater Mothers, so I felt very comfortable that I was in the perfect place if I was going to have a twin pregnancy to go there for checks. But again, it was very sort of much in the door, tick, 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 yep, cool, just a bit of a high five, out you go. So when I mentioned, my swollen ankles and feet, it was very much passed off as, it's normal. And I mean, this is coming into summer as well in Brisbane. So the weather was warming up.
So you continued on for how long, thinking that it was normal?
For a good month, and they started to get worse and worse. So that was the biggest, I guess, looking back, that was the one telltale sign that I probably shouldn't have just passed that off. But, when you raise these things and it's like, no, it's just pregnancy, this is normal. It wasn't normal for me. And I had a desk job. So I was sitting down and I really wasn't moving a lot. And, I was elevating my feet and trying to do everything I could to do, to sort of stop them swelling. And it just kept getting worse.
So can you give me an idea of how much they swelled, like in comparison? Or?
It was just... It looked like my foot, all the toes were just completely joined together. It honestly felt like my feet were going to pop. It felt like there can't be much more pressure unless my feet split. That's how bad it was. They weren't sore, but I'd be able to press my finger into it and that indent would just stay for ages. It was just, the fluid was just, intense, really.
It wasn't until 6 weeks later, at 30 weeks, that Alex was taken seriously.
So it was actually the day of my baby shower. And so the night before I had this really bad headache, like this pressure headache. And they kept saying to me previously, if you feel off, they just kept using the word, if you feel off, go get checked at a hospital, because it could be preeclampsia, but that was kind of it. There was no other... they didn't sort of go through a checklist as far as like swollen feet, headaches, anything else. It was just if you feel off. So the night before my baby shower, I felt off, and because I never get headaches, I started to get it felt like pressure in my head, and I kept thinking, I can't miss my baby shower. So then the next day I got up, went to the baby shower, and I had full-on kaleidoscope vision. People's faces were blurred. I can't even tell you who was there on the day. People were having a conversation with me, and then I found out later they were saying, you seemed a bit vague, but we just thought, it was a scorcher of a day as well. They just said, we thought, because, it was your baby shower and, it was a hot day, we thought you were just a bit stressed. But, I couldn't even see their faces. Everything was just blurred. And then it wasn't until the end of the baby shower that I sort of pulled my mum and my husband aside and explained to them. And of course they flipped out because it's like, you silly girl. My husband took me kicking and screaming to the hospital.
Oh, you were kicking and screaming even then?
Oh, I did not want to go. I was just put my foot down. I guess because I had such the perfect pregnancy, there's in the back of my mind, I didn't want to admit that something was off and something was wrong. But yeah, sort of went in, and because I presented quite well, like, I mean, I was talking and it's like, yeah, swollen, but I mean, I'm pregnant with twins. And they sort of sat me to the side. And yeah, I guess they triaged me that, you know, well, she seems fine. So I sat there for quite a while and eventually went in, hooked me up, checked my blood pressure, and it was through the roof. I think it was about 196 over 124. Wow. And the nurse checked it 3 times. And
to make sure it was accurate.
To make sure that there was nothing wrong with it. She actually thought there was something wrong with the machine. And it's just the look of her face was just burnt into my mind with how panicked all of a sudden she was, because it's like, well, this has probably gone on much longer than what it should have.
And so when you saw her face, how did you feel?
I guess because I couldn't see the blood pressure machine and I was sort of facing the other way, and my husband and her was sitting opposite me, and just pure shock. But yeah, then all of a sudden, then things got moving. So it was very much like, oh, there's immediately 2 doctors in my room. There's someone come in, they're putting a cannula in, and they've turned around and said, you can't go home. We're admitting you now. And you know, at 30 weeks, I hadn't finished the nursery. I had my baby shower. I had all my presents from my baby shower in the boot of the car that was parked at the hospital. There was just so much, I guess, in my mind, and I'm like, I'm just not prepared.
You can't be in hospital.
I can't be in hospital.
Too much to do.
Yeah, exactly. Yeah, I've got furniture to put together and, you know, things to rearrange. Like, yeah.
Belle Rowntree says what Alex experienced were classic preeclampsia symptoms.
As the condition progresses, some of those clinical signs can include things like edema or swelling in the feet, the hands, the ankles, the face. We also keep an eye out for things like severe headaches that don't respond to pain relief, any vision changes, dizziness, referred pain, so pain in the shoulder or pain just under the ribs as well. And also to things like shortness of breath and nausea and vomiting can certainly be part of the picture as well.
Amanda Haberecht.
And it can go up very quickly. You know, she can be, at the moment, I've got one of my patients who she's a twin pregnancy. She is 46. They are donor eggs. So she's at a lot of risk. She's had polycystic ovaries in the past, et cetera, and her blood pressure is just all of a sudden she's developing fluid, and we're at 32 weeks and it's happening kind of quite quickly. So we're really kind of putting on our therapeutic boots. So with her, I mean, she's just a great patient because she's been working with me for a long time. And I've been able to kind of watch her vitamin D and watch her homocysteine and everything. I mean, the great thing with her is she's got no protein in her urine at the moment, but her blood pressure is spiking around. But, you know, we've increased her calcium and magnesium. There's really good evidence for calcium lowering blood pressure. I've increased her vitamin D, which again helps dampen those autoimmune inflammatory mechanisms. Vitamin D is also, you know, obviously so crucial for calcium absorption. You know, choline, there's great evidence and it's emerging. We know choline's the new kind of nutrient on the block with kind of pregnancy and miscarriage risk, but definitely for placental methylation, choline is a crucial nutrient. And, you know, definitely more recent studies and not huge studies, but some great studies to show that it can reduce the risk of preeclampsia. I've also increased her magnesium, you know, using ubiquinol we know that naturally a woman's CoQ10 levels will drop in third trimester and more kind of significantly for our older mums as well. So often in the third trimester, I am prescribing ubiquinol and vitamin E again if we're seeing that. And that's been the thing that I'm watching with this particular patient because the baby's growth, she's got 2 little girls on board, and they're started to plateau. So, and one of the twins we're getting kind of concerned of, so that we know that we need to be promoting blood flow with her. So it's ubiquinol, it's vitamin E, it's arginine. I'm using arginine. So I've used arginine, is again incredibly safe in pregnancy. We've got to watch our patients with herpes. With my patients with herpes, I often do citrulline, which can convert to arginine, and they like the taste so much better. Arginine's got a bit of a awful taste, but you see really good results that we know that both citrulline and arginine will promote nitric oxide, really promote good blood flow. So especially if we're seeing the baby's growth start to plateau, we want to be doing everything to promote nitric oxide as well as looking at her antioxidants.
And what kind of dose of citrulline would you give, or of arginine for that matter?
Well, arginine, you can go up to about, 4 grams really quite safely with it, and a couple of grams of citrulline as well. So it just depends on the patient. You can often get a really good response quite quickly. So obviously you will dose dependent on their risks, what week there are in pregnancy too. Like if we're getting towards the end of pregnancy, and especially if they're talking about, starting to induce that woman, or they're talking about a Caesar delivery sooner, with this patient of mine, she's at week 32 at the moment. So we're doing everything to keep those babies on the inside.
In my mind, I was going to be in there for a couple of days until they fix me and send me home. And then by about day 2, I think I started to bully the nurses, as in I really need to go home. I really, really want to go home. But my blood pressure was not moving. It was just spiking. And even though I was on blood pressure meds at this point, that's when the doctor sort of came in and just said, no, that's it, and I guess I'm like, well, what's the goal here? Are you going to fix me, go home? And then that's when they sort of said to me, look, the only way to cure preeclampsia is to have the babies. And I just hit about 31 weeks at this point.
For the next 2 weeks, Alex Hills was hospital bound.
And in my mind, 35 weeks, if I could just get to 35 weeks, that was a good number to get to. And then it was 33 weeks and 1 day. And I was down in the birthing suite because towards the end, every day I was in the birthing suite because my blood pressure was spiking. I was having to go on IV at this point. And then I'll never forget, the whole group of doctors, all of the different ones I'd sort of met, over the 2 weeks, came in with their clipboards, and they sort of said, look, we can't do anything else. You're going to have your C-section. We've scheduled it for 2 hours. And at first I was like, yep, okay, cool, this is going to happen. And as soon as they've turned to chat, I just lost it. I just started sobbing.
Jane Hutchens is not surprised by Alex's story.
My research has a large part of it was interviewing women with cardiac disease in pregnancy and postpartum, everything but hypertension I'm researching. And lack of or delays in diagnosis or incorrect diagnosis was a really big part of that. And one of the issues, not the only one, is that some of the kind of normal symptoms of pregnancy mirror some cardiovascular symptoms. So why the woman that you're speaking with, they said, no, you look okay, and on paper you're okay. Again, that's kind of why they're moving away from being really strict. Oh, you're not over 140 on 90 and you have no protein in your urine, so we don't care. It's like, okay, well, you don't feel well, you've got some symptoms. Let's just make sure it is not that. Let's see if your liver enzymes are elevated. Let's look at your platelets, that sort of thing. See if she's got any of those digestive symptoms, right up a quadrant pain with preeclampsia. Ask her about her headaches. Are they new? Are they worse? Do they resolve with normal strategies? She's got any visual disturbances, that sort of thing. So part of it is that there's no really clear cut-off line, even though we've got numbers because we have to have some numbers. It is variable across women. It does mimic some normal symptoms of pregnancy. The earlier in pregnancy you are, you shouldn't have any of that. If you're 39 weeks, you might think, no, let's see how you go. But if you're 29 weeks, you think, right, bells go off.
Yeah.
So what I would recommend is persisting and keeping on raising the issue. And that's very difficult to do in general. It's really hard to self-advocate in health. It is harder for women because women tend to be dismissed in healthcare more than men, including, and probably in particular for cardiovascular and pain. They're the two things that they get dismissed about because there's an under-acknowledgement of cardiac disease in women, particularly younger women and pregnant women. And, we're told not to, and to be nice. I sort of had a problem, they said it was okay, now my job's to go away and thank them. Whereas you need to ramp it up. And usually women won't do that until they're scared to death.
Yeah.
Or scared for their baby, even more importantly. That's what motivates most women to take action when otherwise they'd be polite and sit back.
So I guess it's really good to know what you've just mentioned, the things for people to really look out for and know when to push and ask for further help.
Yeah. And look, if I had symptoms like I have reflux that isn't going away with the Somac that you just gave me, or I have this right upper quadrant pain, like even if you don't have preeclampsia, you deserve to have that treated. You deserve to get some sort of resolution from those horrible symptoms.
Yeah.
So we need to look out for the big, bad, nasty things, but we also just need to make people feel better so they don't suffer any more than they have to in pregnancy. So it's just a humanity thing. I think trust yourself as it's harder with your first pregnancy because you've got no idea if this is normal or not. But go with your gut and advocate and just keep advocating. And it doesn't mean you have to be rude. Sometimes you have to get to the point where you start swearing. You have to advocate because the ramifications are too great for you and your baby during pregnancy, during birth, and long term.
What are those ramifications? So, for those women postpartum that you're seeing, what are you seeing as a result of what's happened in pregnancy?
So having hypertension in pregnancy massively increases your chance of having cardiovascular disease thereafter. So at 10 years after having a birth, you're 2.5 times more likely to have any kind of cardiac event if you had high blood pressure in pregnancy. And it's much more than that if you had preeclampsia. So in another study that's looked at more than 1 million people to see their long-term cardiovascular outcomes, women with preeclampsia had twice the risk of developing cardiovascular disease and usually a decade earlier. But if you had metabolic syndrome and preeclampsia, you had 12 times the risk. So that's fairly big. And who has cardiovascular or hypertension, preeclampsia and metabolic syndrome? Women with PCOS. So that's massive. So you're more likely to get cardiac disease and you're more likely that you'll get it 10 years earlier than someone who didn't have hypertension in pregnancy. So it's really, really significant. But even within pregnancy, if you have significant hypertension, particularly if you tip over into the preeclampsia, you have a much greater chance of having a stroke, of having placental abruption, so the placenta peels away before the baby's been born. And the other thing is that you're much more likely to have interventions in birth. And once you have any intervention by a midwife or an obstetrician, it kind of sets off this cascade. And you have one, and it's like, oh, look, now you've got 2 interventions, now you've got 3 interventions, now you've got 4, and we're just about to do the cesarean. And, that might be life-saving and absolutely essential. But there's a very clear path from one intervention, it snowballs. So, and then you have side effects of interventions. So during pregnancy, there's definitely that. You're more likely to have a preterm baby, and the earlier you birth your baby, the worse it is for the baby. Clearly, they can be fabulous, but you want to get as close to 39 weeks as you possibly can. You're more likely to have a low birth weight baby, whether he or she is early or not. And this is hypertension, but you've got vascular stuff happening at the placental level and oxidative stuff, and that may impact on the nutrients getting to your bum. So, lots.
Yeah.
Lots of stuff. But I also would say if you have preeclampsia and you're really sick, you go to ICU, your baby goes to the neonatal ICU, you also have trauma.
Yeah.
So that's what we really need to pick up on as well. For the woman at the time and thereafter, and with another layer of that if she's going to have another baby, because her chances of going through that again fair.
Yeah.
Certainly more than if she'd not had that with her previous pregnancy. And so I work supportively with women and discuss really openly some of those risks. But I also refer to perinatal mental health professionals because there's, I do, from 1 to 4 and they do from 4 to 100. You have to kind of be really clear about how much you can do. But sometimes just having that conversation about, oh my goodness, how scared were you, is enough. It's like, I've not even spoken to anyone about this.
What do you do to manage these women in that postpartum period?
Yeah, I guess it depends, on all the variables. Do I know them? How long ago was it? Are they unwell now? So preeclampsia or gestational hypertension should, depending on who you read, resolve within 6 to 12 weeks postpartum and your blood pressure should go back to normal. Oh, on that, one of the really important things, take someone's blood pressure. It's like, oh, that's really obvious. I couldn't tell you the number of people who don't have their blood pressure taken. But kind of patching up the bits that you can. So if she's depleted in particular nutrients, bump them up. If she's low in vitamin D, if she's anemic, if she's low in iodine, all of that sort of stuff. That kind of just, okay, let's just patch up those bits, and they're foundational things. Really supporting her on sleep and telling her, giving her, some skills around negotiating and saying no. I know that's not a very, well, what medication do you give? But
no,
that matters massively.
Definitely.
So the pandemic was really bad for lots of healthcare issues, obviously, but it's actually really good for women who struggle to set boundaries with people visiting them in hospital and postpartum. So, oh, really? Sorry, I'd love to see you, but I can't. We're in lockdown. So I think I had more women who liked that than didn't, which is interesting. And for all of us, there's that conversation of, well, why are we going to go back to the things that we didn't like?
Yeah.
So is this going to use this as a cue for how you're going to move forward? So managing time, managing sleep. So clearly, particularly in the early days, sleep's just a non-thing, but managing how you manage that. So resting when you can't sleep, resting as much as you can while you're breastfeeding overnight or bottle feeding overnight, all of those sorts of things. And magnesium, nervines, B vitamins, all of those kind of really foundational things, antioxidants, lots of antioxidants, calcium, omega-3 fatty acids. So there's no kind of wildly unique, fancy thing, but it's the person in the situation that's changed. So working with her on that at an individual level and what she needs to do most for her at this time, whether she's 3 weeks or 8 months postpartum. I see people who get to talk about their trauma for the first time 4 years postpartum when they're about to have another baby. And I say, what was it like last time?
And then they start talking about it. Wow.
Yeah, and then they say, my God, I've never talked about that. And look at me, I'm crying. It's like, well, cool, this is a good time to talk about it then.
Absolutely.
Because everyone's like, oh, you got a baby, how cute, let's play with the baby. You're right, okay, cool, let's play with the baby,
Apart from nutritional and herbal interventions and all the should-dos and don'ts, Jane says just listen and support.
And you have to be open to that, and women have to be open to that as well. And we have to be open to the fact that a woman might say, I've got preeclampsia, I'm just bailing and I'm going to a high-risk clinic because that is all I can do because I need to go every 2 days and it's just too damn much. And we have to say, totally cool, I'm here. And that's okay. And we need to not take that on our ego, and we need to not say, oh, listen, she's an idiot because I could have given her fish oil. So, but be there for when she wants to talk about it. So, check in. How are you going? Everything all right? Saw this article on whatever. You might be interested. Hey, look, mindful and maze on. Do you want to go and do 10 minutes meditation a day? And they'll probably contact you postpartum. Let them know there's a lot of stuff that we can do, particularly to help you recover postpartum. So being clear about boundaries and not being offended. Because when you can go from preeclampsia to eclampsia to dead pretty damn quick. So that's not the place to prance around with your ego.
Yeah, exactly.
Because Because really it's not about me.
No.
Damn it.
Alex could not agree more.
I think that was one of my biggest stresses, and I just felt like a failure, like I really did. And I think the other hard thing is because a lot of naturopaths, we're all on those groups, right? I mean,
Yes.
you know, I started joining mums groups, and that was, oh my goodness, that's a whole different ball game. But then when I was looking in the naturopath groups, because I wanted support, I needed support. I'm a very social person naturally, and I was now at home with these 2 babies and needing to know, okay, now what do I do? And I thought, okay, I'll go into, you know, my peers and see what they have to say. And it just was so disheartening. It honestly was so disheartening because I felt like a lot of things were being blamed on women if they chose to do different things. And in my mind, I didn't have a choice. If I didn't have a C-section, I would have died. My babies probably would have died. It was to that point where I'm just like, that was my option. I didn't get to do the whole seeding, and, you know, I didn't get to do the cuddle, and I didn't get to have a choice with, what was going to happen, with the umbilical cord and, all these sorts of things that it's like, you know what, that would be fantastic in a perfect world, but it wasn't a perfect situation. It was like a die situation. And then my breastfeeding journey was just, again, so stressful because I just knew that, you're just trained, right? The breast is best. And when I hear that term now, oh my goodness, I just want to bang my head against a wall because I'm like, no, fed is best. It's just, every situation is so different. And I struggled and I couldn't. And, I even went on medication to try to get my milk production up. And then that, blocked a duct. And then I had an infection. And it just, and it got to that point where I was so headstrong that I need to do this because that's what I think is right, that I was just burning myself out. And thankfully I had my mum and my husband there that was seeing me become this absolute wreck. I had 2 newborns. I was struggling to breastfeed. I wasn't getting enough milk. I was getting up every couple of hours pumping, so I wasn't sleeping. I was still my blood pressure was still all over the shop. And they basically had an intervention with me and said, you got to stop, you need to be healthy to look after them, and this is not making you healthy. And I remember then for the next week, I just cried because we went to formula and, oh no, the devil. And it was just, but I had to. And it was, for me in that situation, the best thing for me because it took that huge pressure off. And it meant that I could be present and I could actually, really look after every other aspect of my babies. And then also my husband could help. So we basically split the babies, and he had one and I had the other one. And in the middle of the night, if we heard one cry, we'd sort of both listen and be like, no, it's yours.
In the next episode of Between Clinical Minds, we continue the conversation, this time on gestational diabetes, with naturopaths Amanda Haberecht, Bill Rowntree and Jane Hutchens. Thank you for listening. We hope this podcast engaged and empowered you. And thank you to all of our experts. You can read more information on each of them on our website, bioconceptsengage.com.au. If you enjoyed this episode of Between Clinical Minds, please refer a friend and share the love. To continue the conversation, you can contact us at bioconceptsengage.com.au, where community is more than a concept.